Thank you, Maya, and thank you for being here on a beautiful Saturday in San Francisco to the bitter end. I have no financial disclosures. This is a shot of Winston-Salem, and it's not quite the view that you get outside of your window here, but we call it home. Now I have 20 minutes to discuss the SCORE project, benchmarking and how it applies to anesthesia quality initiatives that are ongoing today, and then tie everything together with a new serious obstetric anesthesia complication registry initiative that's ongoing right now. Just in itself, quality improvement, patient safety, benchmarking, and reimbursement can be lectures in themselves, and we're going to do all of this in 20 minutes. So it's going to be an overview, and yet hopefully you'll get some important information that you can take home to your practices. So about a decade ago, there were some questions about the incidence of serious complications in obstetric anesthesia, but when you actually look at the literature, there's no large obstetric or even just regular anesthesia databases. So the true incidence was unknown. And an example would be if you look at epidural abscesses. In literature, as frequently as 1 in 2,000 or as infrequently as 1 in 300,000. And I know in our practice, you know, we should be having 2 or 3 a year if it's 1 in 2,000, and we've had 3 in 20 some years. So it just didn't feel right. So put together a serious complication repository. Took us about 6 years to complete it, not yet published. I was actually working on it today, so hopefully this year it'll be out. We had a primary goal. One of the goals was to actually establish the incidence of serious complications. Secondary goal was to make recommendations based on the findings. If you can get enough complications and look at factors that associate with that complications to come up with practice advisories or guidelines that then you take to improve your practice and actually reduce those incidents and improve patient safety. So a very noble goal. 25 institutions participated, and we actually captured data on over 300,000 deliveries and had 85 serious complications that were anesthesia related. And we're not going to go through all of the numbers, and I'll show some slides with lots of numbers on it, but I'll just go through some of the highlights. So we actually had over 160,000 labor vaginal deliveries that received regional anesthesia, and more than 96,000 cesarean sections, all of which received anesthesia. And you can go through the list and you can see that each of these complications happen at incidences of 1 in 4,000, 1 in 28,000, so very rare. The single most frequent complication that we did see was high spinal. There were 58 of them, and we'll talk a little bit more about that in a few slides. This is the rest of the complications that we looked at, and you can see in the middle or at the top that epidural abscess occurred at an incidence of about 1 in 63,000. Now that feels a little bit more right. And we have 95% confidence intervals with this, and those will be reported. With respect to high spinals, there were 14 of the 58 that were unrecognized spinal catheters, 13 of which happened on labor and delivery. So there was a question yesterday, should we be testing epidural catheters? Well, even though it only happens about 1 in 12,000, it does happen, and in each of these cases, test doses were not done. Patients received large dose of epidural, had a high spinal, then had to be resuscitated on labor and delivery. And fortunately, none of these patients resulted in a maternal mortality, but it can happen, and it can happen tomorrow in your practice. So we strongly recommend testing catheters. With respect to the other high spinals associated with spinal anesthesia, 73% had risk factors. The number 1 was obesity, number 2 was a spinal after a failed epidural. So you can see how we can start to see what factors associate with this complication. We just need lots of complications in order to be able to do that. So we were able to actually, with reasonable degree of certainty, estimate the incidence of these complications, and fortunately for us, and as a testimonial to what you all do, complications, serious complications in obstetric anesthesia rarely occur. And maybe we learn from past mistakes and we test epidural catheters and all of that, but it's very rare. But we really didn't accomplish our secondary goal, which was to make recommendations that then improve patient safety, because we just didn't have very many complications. And part of that is the fact that we only had 25 institutions participate, and that's because we wanted numerators and denominators. There are 4 million deliveries in America every year, 1 million C-sections, and if you look at our incidence and multiply it out, there's a lot of complications that are happening, and we need to get and expand that database. So what's the next step? To establish a national obstetric anesthesia complication registry. So when we sat down and talked about it, there's a lot of hurdles that a small organization like SOAP has to do, and we're not going to get into all of that, but most importantly, costs and the legalities involved with that. You have, HIPAA laws, and you need to get government approval in order to set up that database. So it probably was a little bit too much for SOAP to handle. And at the same time, there's coinciding national quality initiatives that are going on at the same time that involve benchmarking, pay for performance. So it's all kind of tied together. And I'd now like to talk a little bit about that. So what is a benchmark? It's a standard against which things are compared, and really what's pertinent for this lecture and for healthcare reform is against the competition. So this is about competition. Now, healthcare benchmarking, and what that means is you're going to get a database. They're going to say, well, the incidence of this is so-and-so. This is what is a good quality measure. And then you compare that. So you look at your own practice and you look at, say, the incidence of high spinals. And, if you have more than what is the average or what somebody says should be, then you try to make changes in your practice to reduce that incidence and then improve patient outcomes. It can be used by organizations such as SOAP. We look at the whole database and then make guidelines or practice advisories, which then you use to change your practice. But it can also be used by other agencies for financial, and I put incentives in quotes. So let's talk about a robust, long-standing database. The Society of Thoracic Surgeons has had their database since 1989, and they've developed 31 quality performance measures, examples of which are the risk-adjusted operative mortality for CABG and preoperative beta blockade. This database is so robust, they have millions and millions of cases. Hospitals pay to participate in this database, and findings from it have actually changed the way that cardiothoracic surgery is practiced worldwide, and a lot of their quality measures are included in CMS and Joint Commission measures and initiatives that are ongoing today. If you haven't heard about this, you will. What are some of those initiatives? Well, this is CMS PQRS, and you can just Google it and you'll go right to the page that I'm going to have quoted down below. It used to be the Physician Quality Reporting Initiative, and now it's changed to System. They're going to use your National Provider Identification Number and your Tax ID number to assess quality measures for Medicare Part B, fee for perform, or for service, pay for performance. And if you go to this website, it's going to say, it says that in 2015, and just, I want you to listen to this, they're going to have payment adjustments to promote reporting. That sounds nice. For eligible professionals. That sounds really nice. They're going to pay you to enter into this system. Well, if you read a couple of lines further, it's going to be eligible professionals that do not satisfactorily report quality measures. So right now, it lists that it's going to be voluntary, but it's going to be mandatory. It's going to involve each of us, and then what they're going to do is have withholding. It's going to start out small and then get bigger. It's just like they do with the hospital systems. 0.5% at first with plans to increase that. You'll be measured against some standard, and if you don't meet up with that standard, then you're going to have reduced payments. Other quality initiatives that are ongoing, CMS Electronic Health Record Incentive Program and Meaningful Use. You're probably dealing with that right now, as well as we all participate in the SCIP measures from Joint Commission. Well, the SCIP measures are already linked to Medicare withhold starting, I think, last year and this year, and they're going to have payment to top performers. So this is an initiative at the hospital level. The previous one in the near future is going to be at the individual level. No such thing as a stupid question. Well, this might be one of them. Pay for performance is not only coming, it's already here, and it's going to impact each and every one of us. So the real important question is, how do we define anesthesia quality? Well, I've just shown you that STS defines their own quality, so no one's telling them, you know, what are the measures. They've done that through their robust database. We don't have any such database in anesthesia. So if we don't do it, somebody's going to do it, and then now it's time for another stupid question, but do you want the government and the insurers telling us what is anesthesia quality? So the ASA has taken the lead. This has been going on for a long time, and they've been working on these issues for about 8 years. And I know there's lots of CRNAs in the audience, but this is one of those times that it's not politically motivated, and the work that's being done by the ASA is going to be able and be applicable to all of us. And everything that I've just said, it doesn't matter anesthesiologist or CRNA, these quality measures are going to apply to you. And I'm not aware of any AANA initiatives that are ongoing, so this will apply to all of us. So what did the ASA do? Starting back in around 2004, they contacted the database managers and directors like STS, even non-medical ones. They met with the anesthesia subspecialty leaders, and they formed a database committee. They had to meet and achieve the same hurdles that I just talked about before with SOAP, but they're a bigger organization with more resources, and they were able to meet all of those challenges. So in 2009, they formed the Anesthesia Quality Institute, and in 1 year, AQI launched the National Anesthesia Clinical Outcomes Registry, NACOR, its database. And the purpose is to benchmark anesthesia practices and practitioners. Right now it's voluntary, and, but in the future, more and more people are going to be required to participate in that, and that will be the system that then looks at anesthesia quality measures. Its goal is to become the engine for the continual improvement of practice efficiency, patient outcomes, and best practice. All right, now it's open to all anesthesia practices, $500 per provider per year. It's free to ASA members. However, Rick Dutton, the head of AQI, is meeting this spring with AANA leaders, and so that may change in the future. In just 2 years, they already have captured information on 8,000 anesthetic cases, but it's still in its infancy, and they still haven't decided what are the anesthesia quality measures that are going to drive a lot of these other initiatives. Now, NACOR right now is not designed to capture specific information on serious complications like we discussed before. So it's not good enough to just know that, you know, you've had a high spinal. We need information on that high spinal, and as much information as possible in order to be able to then make recommendations that translate into patient safety. So AQI, and here's an example. Last week I just received a dashboard on obstetric anesthesia. They have over 545,000 cases. You can see all the practices that are involved with that, but it just tells you little graphs about the age of the patient, ASA physical status, type of delivery, type of anesthesia, but not down to the detail that we need for specific complications. So just this past year, they created the Anesthesia Incident Reporting System, AIRS, and a few months ago launched a joint venture with the Pediatric Society for a Pediatric Complication Registry, and we're working with them right now to develop a obstetric anesthesia complication registry that we hope will be launched in just a couple months. We're pretty far along. The plan is to have links not only on their websites, but on the ASA, AANA, and SOAP websites, and then to get the information out to you. Every time you have one of these serious complications, we want you to go to the website, and we want you to tell us about that. Now, in order for you to actually do that, we have to communicate that to you. It has to be in your mind, and when you go to the website, it can't be cumbersome. So we've gone to great lengths to try to make it easy to navigate, lots of drop-down menus, and then you can enter data either confidentially or anonymously, and it's all protected, so it's not going to be, you know, searchable. And we're not going to be contacting you. So we need the information up front as much as possible. These are the complications that we thought are serious in obstetric anesthesia, very similar to the SCORE projects, but we've added a couple more, blood transfusion reaction, etc. Maybe even though amniotic fluid embolism is an obstetric complication, we deal with it, so that might be another thing to consider to add to this thing, and that's the benefit of it too, is we can always change these things. So this is an example of what you will see whenever you go to this AIR's website. This is the first page. Right now you can go to it, and it's at aqi.org, and there's a test page. So you get to this first page, say I'm going to just do a test page, or confidentially or anonymously. You enter this, you go to the next page. This is for confidential. So it gives you a little bit of information about you with drop-down menus, a little bit about the patient, and then on this page, almost everything that we want about that specific complication is going to be here. On the left is going to be the 13 complications. When you click on it, there's going to be another menu that then goes through questions. You click on it, drop-down menu, answer yes, no, or whatever. Did they use chlorhexidine, etc. So a lot of the questions that we ask at this meeting that you ask in your practice, if we get enough of this, like for example, epidural abscess. So we get 100 abscesses and we find that 92 of them were associated with alcohol only, and we know from other databases that 20% of you guys use alcohol. Well, that's something that we can say maybe isn't a good idea. The last page on this site, it just allows you to do free texting. Is there anything else that we need to know? Because we're not going to be contacting you, so tell us what we need to know about what happened. And when you're done, hit submit. That's it. So for an example, if we talk about epidural abscess, the little drop-down menus will lead you through it, but basically tell us about it. What were the type of regional anesthetic that you used, spinal, epidural? What was the setting? Was it emergency? Did you use a clear drape? What kind of prep did you use? All of that stuff's there. When did they develop the infection? How was it confirmed? And then most importantly, how did you treat it and what was the outcome? So in summary, benchmarking, pay for performance is here, and it's going to impact each and every one of our practices, both at a macro level and at a micro level. I urge you to be proactive because it's going to impact each of you, so be proactive regarding quality improvement, participate in NACOR, participate in the complication registry whenever you have a serious complication, and use the reports, use the benchmarks that come out of these to alter your practice to make it safer for your patients. And if that's not reason enough, the real reason is going to be to maximize reimbursement, which is what they're going to be withholding. So I thank you, and then after the question and answer session, enjoy a beautiful San Francisco evening.